Direct antiglobulin test is called a D.A.T. Some people call it a D.A.T, but that's kind of a non-blood banker kind of term, D.A.T. So it's like D period A period D. Direct Coombs test is also another synonym, and I've heard it called a DAG, although I think that's really an old term. But you could probably call it a DAG if you wanted to. I can't get that thing to work. I'm just going to do it this way. Okay, so the purpose of the direct antiglobulin test is it detects antigens, antibody reactions on the cell surface, and it detects what has happened in vivo. So what has happened in the patient's body. We don't want to do any manipulation, or we want to do as little manipulation as possible, because all the manipulation that we do could influence the reactions that you find, and you want to know, is this happening in my test tube or is this happening in the patient's body? Because it makes a big, big difference what you're going to do as far as an investigation of the positive direct Coombs. Basically, there's autoantibodies and there's passively acquired antibodies. So if you are a baby, for instance, and your mother has an anti-big C, and you have anti-big C, it's not because you have an immune system that has caused the production of this antibody because you've been exposed to the antigen. It's because your mother has the antibody and it's crossed the placenta and it's now in your system. That's a passively acquired antibody. If you happen to be big C positive, then the antibody most likely will attach to your cells and you will have a positive direct antiglobulin test. Okay. Sometimes you have autoantibodies for whatever reason. Sometimes it's drug-induced, sometimes it's clinical condition induced that you have these autoantibodies. People with lupus have autoantibodies, but they're not against red cells, they're against other tissues. So you have other autoantibodies. I had an interesting one yesterday, going back to the passive one. We had a baby whose mother had not been seen at Shands previously and had an anti-Big E. So the baby was born, and I did the direct antiglobulin test, and the direct antiglobulin test was negative. And I thought, oh, this is interesting. So I typed the baby with Big E antigen to see maybe the antibody was being stimulated for something else, because supposedly, according to her history, she had had her prenatal testing done and she had no antibodies prior to this pregnancy. So early in the pregnancy, it was negative. The screen was negative. So I tested the mother or the baby for the E antigen, and the baby was E positive. So it was very interesting because I thought, okay, did they misdraw this baby? Do I have the wrong specimen? He's positive, the mother has anti-Big E. Why are his cells not affected? Or are they so affected that it's looking negative because it's so positive? So then you look for icterus. Okay, how much icterus, how much cell destruction do you think is going on in that baby? So we look at the icterus, and his plasma was really clean, and it was really clear, and it was really pretty. So then I go back to my original hypothesis, was that they misdrew the specimen. But we determined it was an IgM, so the baby was somehow or other stimulating the mother's production of anti-E, but had not gotten beyond the IgM into the IgG phase yet. So it hadn't crossed the placenta, it hadn't affected him yet. So he was perfectly fine, but she now has the antibody. So the direct Coombs can give you a lot of information as far as what to anticipate is going on in the patient's clinical condition. Okay. When you look in your reagents, you have 2 new green reagents. One of them you used last week when you did your week D. That's anti-human globulin, which is an antibody to an antibody. Okay. There's one that will say polyspecific is IgG and C3b or C3bb, and the other one will say IgG. So those are our new reagents. And then, of course, we have our friends, the check cells, that were added. So we're going to use those today. Okay, so when we're looking at direct antiglobulin tests, the reason that we run direct antiglobulin tests is to determine if somebody has anemia. Is it autoimmune hemolytic anemia? Do they have an antibody against an antigen that they have that's been turned on somehow or other, and they're lysing their own cells? Do they have hemolytic disease in the newborn? Of course, you know the age of the patient is going to be a big clue in that case. Do they have a hemolytic anemia that's drug-related? Because that's going to cause you to have a warm autoantibody, and it's going to cause you to have, in a lot of cases, a positive direct antiglobulin test. And the final one is, did you get a transfusion? And are we really looking at a transfusion reaction? Are we looking at an antibody against those donor cells, and the antibody is coating those donor cells, and it looks like a positive direct Coombs because those donor cells have become yours now because they're in your system. So use it for these four arenas for the most part. All right, so when you do a direct antiglobulin test, like I said, you want to do as little manipulation as possible. So you're going to take your patient cells and you're going to wash them. You're going to wash them 4 times, or you're going to make a cell suspension and you're going to put a drop in a tube and you're going to wash that drop 4 times. And you're going to shake it in between, and you're going to blot it dry just like we washed the week D. And so what's going to happen is if there's antibody that's already coated on the patient's cells, then you're going to add the anti-human globulin, which is the antibodies to antibodies. It's going to go in, and it's going to find that antibody that's coated the cells, and it's going to agglutinate, and then you're going to be able to see a positive reaction. Okay, so the reagents that you have in your rack are polyspecific and IgG. Every blood bank is going to have both. You need to have both so that you can investigate, because it's going to make a difference whether you're dealing with a positive direct antiglobulin test that's due to IgG or has some element of complement involved in it. Some positive direct antiglobulin tests are only complement. People have cold autoantibodies. And so the only artifact of their reaction is complement fixation. So you have these different antiseras. Typically, blood banks will use one or the other routinely. There's 2 different schools of thought. The one school of thought is that IgG antibodies are the antibodies that we care the most about. So we're just going to test for the IgG and we're not going to worry about the complement. The other school of thought is that there are some significant antibodies are IgG, and they also bind complement. And a lot of times they have a weaker reaction. So if we use polyspecific Coombs for routine testing, then we're more likely to determine the existence of these kinds of antibodies than if we just use the IgG. So that's kind of the mindset. Neither way is necessarily correct. It's just whatever the philosophy is. But the moral of all of this scenario is that you have to have both, because you have, for a differential direct Coombs, you have to have both. If you're dealing with a positive direct antiglobulin test or a direct antiglobulin test on a baby, it really doesn't matter whether you use the polyspecific or the IgG, because no matter what, it's going to be IgG. If it's coating the baby cells, it's got to be IgG. And so whichever one you use, you know what the answer is. If you're dealing with anybody who's more than 4 months of age, and you're doing a direct antiglobulin test, you need to use the poly first. You need to use the poly first, and if it's negative, your direct antiglobulin test is negative. If it's positive, then you want to know, is it IgG, or is it complement, or is it both? So then you will go and do the same test again and use anti-human globulin, this IgG this time. Now, if the antihuman globulin is IgG positive, terrific. Is it positive for Coombs, IgG. If it's negative, it's most likely complement. There are a few direct Coombs that can be attributed to IgE and IgA, but they're very few and far between, and I think there's probably only one facility in the whole country that I know of that even does those kinds of direct antiglobulin tests. Usually it's all an IgG or not an IgG. There are reagents that will just check for complement, the complement antihuman globulin. It's very, very expensive. It's not very, I guess, easy to store because it becomes deteriorated very easily. And so your reactions are weak at best most of the time. Your check cells, it's very difficult to take a cell and only coat it with complement and not get any kind of antibody involvement at all. So the check cells are very expensive and they are not very stable at all either. So some places will go ahead and do the differential direct Coombs where they'll do the poly, and they'll do the IgG and the complement. Some places will do the poly and then do the IgG and call it direct antiglobulin test IgG positive or direct antiglobulin test IgG negative. Most of the time, that's all anybody really cares about. So whether or not there's complement involvement really is irrelevant to the big picture. Does that make sense? Okay. Okay, so when you're doing positive tests or you're doing direct antiglobulin tests, you can get false negatives, which happens. You're going to take your cells, you're going to wash them, you're going to add your antihuman globulin, you're going to spin it down, you're going to read it, and if it's negative, you're going to add check cells. Okay, if your check cells don't work, what do you have to do, John?
Make sure your check cells are in date.
Make sure your check cells are good. That's one of, let's see, inadequate blotting, weak cell suspensions. Okay, well, I guess it's left off of there, but yeah, if your check cells aren't working, your test could be a false negative, that's for sure. But if your check cells don't work, you've got to go back to the beginning and try again. Either using different check cells, using different antihuman globulin, or just using different amount of time, or making sure that you're a little bit more precise in your technique. So if you don't wash it enough, in between the washings, if you don't shake it enough to make sure that you're getting the cells resuspended after it's spun down, if you don't blot the final wash, then there's too much supernatant left there, and so the antibodies just kind of float around in the mixture and it can't find the antigens to be able to attach to. If for some reason your antihuman globulin has been neutralized or is no good, or is old, sad, and tired, if you forgot to put antihuman globulin, our antihuman globulin is green, but you can't buy it clear. And so if you have clear antihuman globulin and you forget to put it in, you have false negative. If you don't centrifuge enough, you might not get the antigens and the antibodies close enough together so that you find a positive reaction. And the specimen being more than 48 hours old, a lot of times what will happen is the complement will deteriorate, and if it's reliant on the complement, you could have a false negative in that case. And of course, if you have a cell suspension that's so weak, you have a prozone effect where all the antigens and the antibodies are attached, but they're so far apart that you don't see the actual reactions themselves. Okay, so false positives, you have contamination. You have contamination of your tubes, you have contamination of your saline, of your antihuman globulin. I suppose you could have it of your cells, but that's sort of with the saline of the tubes. If your cells were agglutinated before you ever even started, if you had a clotted specimen, for instance, you could see something that looked like a false or looked like a positive when really and truly it was just the fact that it was a clotted specimen to begin with. If you don't resuspend your cell button all the way, so you didn't read it properly, and if you centrifuged it to death so that all the cells just kind of clump down to the bottom, they could come off very raggedy and look